Hi everyone, and welcome to the RTI3 pre-conference webinar. I'm Grace Lee, and I'm joined by Tara Rosewell, and we're both hosting this webinar today. We're super excited today to have Natalie Rosnick with us today, an expert in palliative radiotherapy. She's a CSRT, and she's going to be talking to us about advances in palliative radiotherapy practice today in the webinar. So I know a lot of people will know who Natalie is, but for those who don't, I have a brief bio about her. So Natalie graduated from the Radiation Sciences program at the University of Toronto and Michener Institute in 2009. She's been working at the South Lake Regional Health Center since 2010, where she has worked both as a radiation therapist and clinical trials coordinator. In 2012, Natalie began working as the clinical specialist radiation therapist, or CSRT, in palliation, and currently sees patients through the South Lake Rapid Response Clinic. Natalie has been involved in several research projects and initiatives focusing on improving patient experience and also palliative radiotherapy at SRCC. She's also working towards her MSc in Advanced Practice Radiation Therapy and Oncology at the Sheffield Hallam University. So I'll give the time to Natalie now. You may have some questions during her talk. We encourage you to put in any questions in the chat option you see in the GoToMeeting. So during her talk, you can start putting questions there. Natalie will be answering questions towards the end of her talk, and we'll have about 10 minutes or so for her to take any questions and also to answer any questions from the chat. So you can really use the chat option as well if you have any burning questions for her. Okay, so I'll give the time over to Natalie right now.
Thank you very much, Grace, for the kind introduction, and a big thank you to the RTI3 committee for inviting me to speak to you today about advances in palliative radiation therapy practice. As Grace mentioned, my name is Natalie, and I'm the palliative clinical specialist radiation therapist at South Lake in Newmarket. The clinical aspects of my practice involve seeing our patients both through our rapid response clinic and in our Radium 223 program. I'm looking forward to discussing some interesting changes that we are seeing in these areas that are having profound effects on our palliative population. So I have no conflicts of interest or disclosures at this time. Today, I'll be explaining about some of the recent advances in palliative radiation therapy practice. I'll touch on some of the prominent literature in this area, and we'll take a look at both the pros and cons associated with each topic. I'll also touch on benefits for patients, and we'll have a bit of a chat about decision-making and the importance of good prognostication. So in the spirit of remembering where we came from as we continue to move forward, I'd like to introduce you to Dr. Harold Johns, inventor of the Cobalt-60 radiotherapy unit. The first radiation treatment was delivered in Canada in 1951 in Victoria and dramatically improved survival rates for cervical cancer. So this is an image of Dr. Harold Johns showing his Cobalt unit to Princess Margaret herself at the Princess Margaret Hospital in Toronto. The unit was in operation until 1972 and paved the way for development of the modern-day linear accelerator, dramatically changing outcomes for our cancer patients. Despite the advances and improved cure rates in cancer care over the years, we are still caring for a large population of patients with metastatic disease. For these patients, the concept of palliative care becomes extremely important. And as clinicians, it's extremely important that we understand what this means for our patients and help ensure that they are connected to the appropriate resources in a timely manner. A study from 2011 demonstrated that simply making the referral to palliative care services is associated with improved quality of life and outcomes. It also minimizes the patient's and caregivers' distress and helps to provide appropriate measures at the end of life. So how do we define palliative care? According to the World Health Organization, Palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems. And it involves physical, psychosocial, and spiritual elements. When we use radiation therapy in the palliative setting, the majority of our patients treated receive radiation to help with pain control, a large part due to the presence of bony metastases. Another common site of treatment that we see is the brain for metastatic brain lesions. However, there are several other indications for palliative radiotherapy that you may or may not be familiar with. So to name a few, we can look at treating leptomeningeal disease, spinal cord compressions, lymphadenopathy that is painful or causing edema for our patients. We can treat choroidal metastases to try and preserve vision, treat obstructions, painful or ulcerated skin lesions, dysphagia, bleeding, and pain from extracapsular liver metastases. Palliative radiation therapy traditionally has involved short courses of treatment with one or just a few fractions, and from a planning perspective, usually has involved simple beam arrangements. A large dose per fraction is usually delivered with the goal of improving a patient's symptoms. So for example, to improve pain or stop bleeding, to dry up an ulcerated skin lesion, or stop or prevent obstruction. With respect to dosimetry, classically we've looked at parallel opposed pairs and simple field arrangements. But we're moving forward. With the advent of new technology has come the development of new techniques that have allowed us to improve upon the original and simple POP. Although this parallel opposed pair is still widely used today for palliation, we are also looking at the use of junctioned and matching fields, VMAT, and IMRT to try and increase dose conformity, which can provide several advantages to the patient. Being able to provide palliative patients with more conformal planning means that we can dose escalate our targets and decrease the dose to organs at risk. This is really important as it can potentially decrease the side effects for treatment for our patients. When we think about the goal of improving quality of life, particularly in a population of patients that may already have a poor or a decreasing performance status, we want to ensure that the proposed treatment and its side effects are manageable and that we are not doing more harm than good in the long run. As we move beyond the POP, one area that has had a significant effect on palliative radiation therapy is the use of stereotactic radiosurgery or stereotactic body radiotherapy. According to Mulroy, stereotactic radiosurgery or SRS is a non-surgical radiotherapy technique used to treat small tumors of the brain. It can deliver precisely targeted radiation in fewer high-dose treatments than conventional radiotherapy, which can help preserve healthy tissue. When SRS is used to treat body tumors, it's referred to as stereotactic body radiotherapy. So we can target brain lesions, spine lesions, many lesions throughout the body. With respect to stereotactic radiosurgery, when we consider this type of treatment approach for patients, a common approach is to review the patient's case in a multidisciplinary group setting to consider factors such as the extent of disease, both
Thanks.
seeing whether surgery is an option, considering factors, for example, like the patient's age, what is their performance status, how well controlled is the primary, how big is the lesion we need to treat, located. Is it amenable to stereotactic radiosurgery, or would traditional surgery perhaps suit them better? We're looking at. We're just going to pause for one moment here. And just adjust our audio. There we go. Sorry, continuing along here. When we're looking at treating multiple lesions throughout the brain, would we perhaps need to look at whole brain radiotherapy, Or are we looking at single solitary lesions? Do we need more imaging to make a final decision? So we'll take a look here at some general guidelines. So for single solitary lesions, stereotactic radiosurgery may be appropriate for smaller lesions, lesions that are inaccessible by surgery, or for patients that maybe aren't surgical candidates. Postoperatively, we can also use this technique to treat the surgical cavity. If we look at 1 to 4 lesions, in different centers, often we're looking at stereotactic radiosurgery plus or minus the possibility of whole brain radiotherapy, depending on the situation. In the case of recurrent lesions, we can use stereotactic radiosurgery for approximately 6 or less lesions that would be less than 3 centimeters in size. And again, I mentioned earlier that these are examples of general practice guidelines, and we do have variations amongst different practitioners and different centers across the province. So in terms of the pros and cons of stereotactic radiosurgery, we know that stereotactic radiosurgery has the potential to provide excellent local control of lesions. Because the treatment is highly focused, there can be fewer side effects when compared with traditional whole brain radiotherapy. On the flip side, because of the fact that stereotactic radiosurgery is so focused, it doesn't necessarily address the issue of potential microscopic disease that could be located elsewhere throughout the brain, which would traditionally be included and treated in a whole brain field. So at this time, I would like to play a brief video for you. This video is featuring Dr. Arjun Sagal from Sunnybrook Hospital, and he's going to be just explaining a few more of the benefits of stereotactic radiosurgery, in particular, some benefits that are very important for our younger group of patients. So I'll turn it over to Dr. Arjun Sagal.
We have taken the approach here at the Odette Cancer Center to use radiosurgery alone for several years now. We've really believed in this approach. We've used whole brain radiation sparingly, more as a last resort type of therapy for when we can't use focused radiation because there are too many spots that have arisen. In order to validate that practice, we asked some of the leading authors of the randomized studies around the world to give their individual patient data to us. And together with some statisticians and McMaster, we put the entire cohort or group of patients together and looked at what the effects were of just focused radiosurgery as opposed to whole brain radiation plus radiosurgery. And what we found was that patients who were treated with just radiosurgery did better than if you were given whole brain radiation plus radiosurgery with respect to survival. Patients who were 50 years and younger really had that survival benefit. Otherwise, for older patients, there was no disadvantage. And it's not just survival, but patients' quality of life, so their ability to lead their normal lives with less fatigue, appetite loss, or better mood. That's all better with just focused radiation as opposed to whole brain radiation. Now, it's hypothesis generating, meaning that we further have to understand why we're seeing this effect, but it is a very interesting and provocative result that is going to impact practice in the sense that more people would be inclined to use just radiosurgery, a focused radiation approach, at least for patients who are 50 years and younger, who present with 1, 2, or up to 4 tumors, as opposed to adding on whole brain radiation. And this practice is currently being endorsed by some of our major institutions, like the American Society of Therapeutic Radiation Oncology, who recently came out and said that if you're going to treat with focused radiation, don't add the whole brain radiation after. So if you can, treat with focused radiosurgery, save the whole brain radiation for later. There are obvious benefits that have been proven in studies with respect to quality of life and memory functioning, and now we've shown some data to say that you may actually live longer, especially for patients who are 50 years and younger.
So there's been a lot of talk lately and a lot of buzz around interest in treating oligometastatic disease. When we look at the literature, Hellman and Weisselbaum originally proposed the state of oligometastases in 1995. based on a consideration of what they called the multi-step nature of cancer progression. They proposed the existence of an oligometastatic state that was an intermediate between purely localized lesions and those that are widely metastatic. The state was described as being amenable to a curative therapeutic strategy, amenable to localized therapy, and is very attractive if you think about it. And it can potentially be reality for a specific subset of carefully selected patients. According to Hellman and Weisselbaum, the distinguishing characteristic of oligometastases and the purpose of the local treatment for this is based on the concept of curability as the outcome. So there are clinical trials going on right now that are looking at oligometastatic treatment. So for example, the 5-fraction stereotactic body radiation therapy for oligometastases regimen for extracranial oligometastases. This is in progress and set to close in 2022. So this is looking at patients with any solid tumor, excluding those with lymphoma, myeloma, and germ cell tumors. Histologic confirmation of disease is needed, and a radiological diagnosis of oligometastatic disease has to have taken place. As far as the oligometastases, a maximum of 5 lesions can be included, and at least one of those lesions has to be suitable for stereotactic body radiotherapy. All known sites of disease have to have some sort of plan for local ablative management at least within 3 months. Patients need to be 18 years of age or older and have a reasonably good performance status of ECOG 2 or less. Patients were excluded if they had previous radiotherapy to the intended treatment site or if they were unable to tolerate the physical setup required for SBRT. Patients who potentially needed treatment to an abdominal or pelvic site and had active bowel obstruction were excluded, and those who had chemotherapy within a couple of weeks of intended treatment were also excluded. In terms of outcome measures and what this study is hoping to look at in detail, they want to track the proportion of patients that lack progression of disease at the treatment site at the 1-year mark, and this will be evaluated using CT scans. Acute and late toxicities within the study period will also be tracked, and they want to look at the time to local progression as well. In addition to this, they're hoping to be able to put together a symptom profile for these patients and look at the different parameters regarding radiation therapy to develop a local control index site. So this study right now, as I said, is in progress, and we'll see what happens. 2022 will be very interesting, and I'm sure that the data that comes out as a result of this will have significant impacts across the board for our patients. Another area that has been a hot topic recently involves sparing the hippocampus during whole brain radiotherapy. So we know that the hippocampus itself is involved in memory, and that whole brain treatment can potentially cause damage to the hippocampus. With patients, this can affect their short-term memory after completion of radiotherapy, and it's a side effect where if it happens, it can cause significant stress to both the patient and their families. So if we take a look at the diagram here, you can see where the hippocampus is located. And when we compare to the DRR on the right, you'll see that it does fall within our whole brain fields. So several groups have looked at whether damage to the hippocampus can be minimized or avoided, and if this truly makes a difference for our patients. So an article that came out of the RTOG 0933 trial in the Journal of Clinical Oncology was a really good analysis of this. So this was preservation of memory with conformal avoidance of the hippocampal neural stem cell compartment during whole brain radiotherapy for brain metastases. It was published in 2014 by Gandhi's group and looked at delivery of whole brain radiotherapy using IMRT or VMAT. And an area of expansion around the hippocampus, 5 millimeters in size, was generated and used as an avoid function. So all of the patients here received 3,000 centigrade in 10 fractions of treatment, and they were administered something called the Hopkins Verbal Learning Test Revised Edition at the 4-month mark after treatment to test delayed recall. So they accrued 113 patients to this study, and 4 months post-treatment, there were 42 patients who were able to be completely analyzed. In terms of results, they did show that conformal avoidance of the hippocampus during whole brain radiotherapy is associated with preservation of memory and improved quality of life. This was compared to a historical value of 30% cognitive decline noted with traditional whole brain fields. And in this study, they saw just a 7% decline here, which was significantly better. Now, there are several pros and cons of using this approach. We've seen that sparing the hippocampus during whole brain radiotherapy can preserve short-term memory, but the challenges associated with this, many of them can be a bit technical in nature. So for example, in the study, all of the patients had MRIs completed, which were then fused to the planning CT dataset. So this was done to assist with contouring and accurate localization of the hippocampus. Currently, although many of our patients who move on to whole brain radiotherapy do have completed MRIs, not everyone does, and it really depends on the circumstance and urgency leading up to that patient's treatment. There are also other technical challenges. So for example, being able to fuse an MRI properly depending on where the MRI was performed, at a different institution, at your own institution, when we look at calibrations and privacy and all of these different things put together, it can be quite tricky to actually make this happen. We also want to make sure that we have accurate delineation of the hippocampus, or there's really no point. If we have a geographic miss and we're sparing something else, this likely will not result in improvement or preservation of short-term memory. The other consideration that we need to look at carefully here is that more complex planning techniques are used than a parallel opposed pair. So in this study, we looked at VMAT and IMRT. We think about the amount of time it takes to generate a more complex plan, in addition to providing the correct quality assurance for these treatment techniques. When we have a patient that comes in and may need same-day treatment or very urgent treatment, being able to complete all of those tasks in a safe way may not necessarily allow us to give that same-day treatment or the urgent treatment that would be in the best interest of the patient. Another really interesting area that has come about recently over the last several years is treatment with radium-223, otherwise known as Xofigo. So this looks at treatment for castrate-resistant metastatic prostate cancer patients with bony metastases. And it is a treatment being given in Ontario right now for this population. The study was published in 2013 in the New England Journal of Medicine by Parker's group, and it looks at delivering an infusion of radium-223 to patients with metastatic prostate cancer. These gentlemen do have castrate-resistant disease, so they had disease progression while receiving androgen deprivation therapy. The patients had bone-only metastases, and on study, they received IV infusions of either placebo or radium-223 once a month for 6 months. The mechanism of action of radium-223 is actually quite interesting. If we take a look at the slide here, we have a bone scan from a prostate cancer patient with multiple bone metastases, and you can see the multiple dark spots in the shoulders and the spine and the ribs up on the screen there. And so radium-223 on the molecular level is very similar to calcium. So when we infuse a patient with radium-223, it actually tricks the bones into thinking that they're receiving calcium and allows the bones to selectively take up that radium. Later on, the radium does become excreted through the patient's bowels. So radium-223 works as an alpha emitter, and it can deliver concentrated radiation via shortwave alpha particles directly to multiple bony metastases. This can cause double-stranded breaks in the DNA and tumor cell death, etc. So I have a brief video explaining a little bit about this trial from the New England Journal of Medicine, and I'll just bring that up on the screen for you. Here we go.
This is Jeffrey Drazen for the New England Journal of Medicine. Bone metastases are a frequent and serious complication of prostate cancer. Once tumors metastasize to the bones, severe pain and pathologic fractures can occur. Death from prostate cancer is often due to bone disease and its complications. Is there anything we can do to help patients with prostate cancer who develop bone metastases? We have published a trial that compares the efficacy and safety of adding radium-223, which I'll just call radium, or placebo to standard of care in more than 900 patients with bone metastatic, castration-resistant prostate cancer. How does the treatment work? Radium, like calcium and strontium, is taken up into bones, and the isotope emits alpha particles with high energy, short path lengths, and reasonably short half-lives, thus potentially killing cancer cells while minimizing the innocent bystander side effects. The study recruited men with confirmed bone metastatic prostate cancer who were resistant to other forms of treatment. Radium or placebo was given to the patients once a month for up to 6 months. The primary outcome was overall survival. The study was stopped early when about half the expected deaths had occurred because of the efficacy of the radium treatment. The median survival rate was about 15 months in the radium group versus about 11 months in the placebo group. In addition, a significantly higher percentage of patients treated with radium experienced a meaningful improvement in other secondary outcomes, including quality of life. There were fewer adverse events in the radium group, while there was no difference in hematologic side effects. Targeted treatment with radium-223 benefited men with metastatic prostate cancer. There were minimum side effects. The treatment did not stem the basic disease, but helped bring painful metastases under control.
Okay. So, as mentioned in the video, in terms of the patients that were included in this study, we were looking at gentlemen with castrate-resistant metastatic prostate cancer that had at least 2 consecutive rises in their PSA values that had to be documented to be at least a week apart. They had to have several metastases within the skeleton and no metastases in the soft tissues, so bone-only disease. Patients had to require continuous pain medications or had received external radiotherapy to address bony pain. They had to have reasonably good performance status of ECOG 0 to 2, and because the radium treatment itself takes 6 months to administer, they needed to have a life expectancy really of at least 6 months or more to benefit. Just like other therapies that are administered systemically, there were minimum laboratory requirements to ensure the safety of these patients, as the radium can sometimes affect bone marrow and cell counts, and these were checked throughout treatment. In terms of exclusion criteria, patients were not eligible if they could perhaps go on to receive docetaxel or if they had received investigational drugs leading up to the radium treatment. If they had had prior hemibody external radiotherapy or had required blood transfusions within the last 4 weeks, patients were excluded. We also, the study group, also excluded patients who had a history of visceral metastases. So if you think about the radium being selectively taken up into the bones, It won't be taken up into the organs themselves. So to provide a patient with radium-223 treatment who has a significant amount of metastatic disease in the soft tissues may not be the best idea, in that we won't be treating those areas of disease at all with the radium. Patients that had an imminent or an established spinal cord compression were excluded from the study, and those who had medical conditions, for example, Crohn's disease or ulcerative colitis, or who had unmanageable fecal incontinence were not allowed to participate, mostly from a safety perspective, in that the radium-223 is excreted through the bowels. So if you have someone who already has issues with their bowels, it could cause significant trouble for them. And it could also cause, from a safety standpoint, significant exposure issues if there's a lot of fecal incontinence and patients need assistance with self-care. As far as side effects, the most common side effects from from radium treatment on the study were nausea, vomiting, diarrhea, fatigue, lower blood counts, and peripheral edema or swelling. Very rarely, patients had experienced some dehydration, a reaction at the injection site, or kidney failure and impairment. Overall, the treatment itself is extremely well tolerated, and patients that were on study also received special instructions for self-care to make sure that as the radium is excreted, the patient and their caregivers are doing things safely. So pros and cons of radium-223. We've seen from the data that an increased survival of approximately 4 months was noted in those that received radium-223. Bony pain had improved, and the treatment itself was very well tolerated. Additionally, you can treat multiple sites of bony metastases all at once, as opposed to just focusing a beam of radiotherapy on a painful spot. There were also some challenges with radium-223 treatment. The treatment course itself is long. It does take 6 months to complete. So ideally, our eligible patients need to have a life expectancy of greater than 6 months so that they can both complete the treatment and receive the benefit that comes from it. We know that the radium-223 treatment can affect bone marrow and lower cell counts. So patients are continuously monitored during this treatment to ensure that blood counts are at safe levels. Patients' performance status had to be ECOG 2 or less. So they had to be ambulatory and capable of all self-care and up and about more than half of the day. We already talked about how this is important because of the exit route for radium-223, excretion through the bowels. So we want to make sure that we're delivering treatment to someone where there's not necessarily an accident or exposure to their caregiver. More recently, we're seeing some interesting data coming out. So if we look at a paper from October of last year, there was a publication by Sartor and Nordquist, and this was looking at some of the first data about whether it's considered safe to retreat patients with radium-223. So this initial study looked at 44 patients and did conclude that retreatment is also safe and well tolerated after disease progression, but also noted that we do need some larger trials to look into this further. Interestingly, in terms of future directions, we also have another trial going on at the moment, and it's looking at radium-223 in combination with hormonal therapy and denosumab in the treatment of patients with hormone-positive, bone-dominant metastatic breast cancer. So this is set to be completed in February of 2021. And it'll be interesting to see if in the breast cancer population the same benefits are seen as in the group of prostate patients that were also treated. So as you can see, we've had several developments in palliative radiotherapy over the last several years that have affected our practice significantly. And this has been coupled with the development of systemic therapies and resulted in better outcomes. So we have patients living longer now in the metastatic setting. And with these longer life expectancies, We're sometimes seeing our patients several times for palliative radiotherapy retreatment. But how much retreatment is safe? And should we always take out the full arsenal of tools for everyone? Many of the previous studies and papers, if we look at AMAMI or the Quantec papers, they look at safe tissue tolerances for radiotherapy that really may be more relevant to curative doses and curative fractionation patterns, or stereotactic doses. On the flip side, when we retreat and we worry about late effects, is there a possibility that maybe we're being too conservative with our approach in the palliative setting, where life expectancy after several retreatments may be shorter than the time period associated with an onset of late effects that we get worried about? So prognostication. To answer these questions, we really need to have a good understanding of life expectancy. The challenge here is that as healthcare providers, studies have shown that even with many tools that are available to us, unfortunately, we're not always the greatest at estimating life expectancy. So this is just an example of one of the tools that's available that people can take a look at. It's called the Palliative Prognostic Score, which gives the probability of a patient being alive in 30 days based on several factors that you can see listed on your screen there. When pain relief from radiation therapy can take a few weeks to occur, or we're considering a radium treatment that takes 6 months to complete, a 30-day time frame really may not be the most useful clinical tool for us. So there are other tools that have been developed. Another one is called recursive partitioning analysis. And this looks at the Karnofsky performance status, age, extent or controllability of disease as indicators for life expectancy. This tool looks at median survival in months, which can be a bit more useful perhaps than the 30-day point that we were looking at previously. But at the end of the day, as good as the tools can be, there are a lot of unpredictable factors that can affect life expectancy both positively and negatively in our palliative patient population. So decisions, decisions, decisions. We know that when we look at the data, that as healthcare professionals, we tend to overestimate life expectancy. So if we are treating a patient with palliative radiotherapy, we want to know that the life expectancy is long enough that they will be around to complete the treatment and receive benefit from the treatment. Because of the fact that this takes several weeks, we really need to take careful consideration to this to make sure that the patient is really embarking on something that will be beneficial rather than a hindrance. But as I said, we don't have a crystal ball. So I've put this up here because I think this is a really important point to remember when we're looking at all of these advances in treatment. So the little rectangle says, I hate making decisions, and the chicken says, just remember, choosing not to choose is also a choice. And he asks, so by doing nothing, or sorry, by doing anything, by not doing anything, I'm actually doing something? That's great. So this is really important, square man and chicken aside here. So sometimes with all of the advancements we've made, the best decision for a patient is to receive comfort care and not proceed any further with treatment. Don't mind the siren in the background. Everyone's fine on our end over here. So this decision to not take on any further treatment can be really difficult for a patient. For example, they may not want to disappoint their family by stopping treatment, but they have no desire to necessarily move forward with more chemotherapy or more radiation. And as healthcare professionals, providing support to the patient during this time so that the right decision can be made for them is extremely important. For patients dealing with a terminal illness, maintaining hope and reasonable expectations can have significant effects on quality of life. Kate Weingarten, who's a family therapist, explained a term that she calls reasonable hope in an article published in 2010. She discusses how reasonable hope suggests something that's sensible and moderate and directs our attention to something that is within reach. And one of our fellow radiation therapists, Karina Fuse, she works out of the Princess Margaret Hospital, a few years ago published a literature review that looks into hope fostering strategies and the concept of reasonable hope. And the article is called Hoping for the Best While Preparing for the Worst, a literature review of the role of hope in palliative cancer patients. This was published in the Journal of Medical Imaging and Radiation Sciences in 2012. And it's an excellent read for anyone that's working in a palliative care setting on how to foster hope within the clinic in situations where a cure is not necessarily something that's on the table, but you want a patient to have meaningful time, good quality of life. And I would strongly suggest you take a look at both of these articles because they're great reads. So the use of these hope fostering strategies within the clinic are very useful, and they can really help keep perspective at a time where difficult treatment decisions need to be made. So in conclusion, we've had an opportunity to look at a few of the advancements of palliative radiotherapy practice and how they can be used to improve quality of life for patients. As clinicians, we need to make sure that we are carefully selecting patients for these new and novel treatments as we move forward to ensure that the best treatment is going to the correct patient. And at the end of the day, we want to make sure that whatever treatments we deliver are allowing us to support our patients in the best possible way and respect their wishes during their disease trajectory. So thank you very much for your time and attention. I'm happy to take some questions. And just before I do that, I would like to give a big thank you to my colleagues at Southlake and to Grace, Tara, Nicole, and the RTI3 Planning Committee. The people on this list have been inspirational over the last several years and have been very helpful when putting together the different elements of this talk. So I just want to send a big thank you out to all of them. And I'm happy to take some questions.
Thank you so much, Natalie. That was absolutely amazing. If you have the capacity to type your questions into the chat section of GoToMeeting, please feel free to add any little questions you have. Okay, we're going to open up the microphones so that anyone who would like to ask a question verbally is able to do that in order to have some order for the process. We're going to maybe start with anybody in British Columbia who has any questions or comments for us. Nope. Anybody in Ontario who has some questions or comments for us? Is there anybody from any of the other provinces who would like to ask a question?
Right? Ontario and any other provinces? Yeah.
Who cares?
Okay, that's great, thanks. So there's been a few comments come up on the chat line to thank Natalie for her presentation and to let her know how much and a comment on how beautiful her children are.
So too.
So if nobody has any questions, burning issues that they would like to raise at this point, then we're going to sign off and say thank you to everybody who has paid attention through the course of this wonderful talk. Thank you very much. Yep, okay.